So 45-year-old male presents with finger pain after he slammed his finger in a kitchen cabinet door. I'm sure you guys see this all the time. What do you see? Just call it out. What do you see on this x-ray? Avulsion fracture. And what was avulsed? What's there that gets avulsed? So yeah, that's the extensor tendon. So it's the extensor tendon avulsion at the distal phalanx. What's the other name for it that we always use? Yeah, mallet finger, right? So that's a mallet finger. And how do you treat these if they come in to see you? I see him showing me a finger and extension. What do you tell your patients about the finger and extension? And how do you splint them? Yep, so hyperextension almost, because you want to get that edge close. And what do you tell them when they leave you about that finger? Can they take it off to wash their hands? Can they take it off to shower, to wipe their tush? Anything? No. They shouldn't take it off at all. For how long? 6 weeks. Believe it or not, these patients can all be managed by you guys. If you had a follow-up program wherever you are, they can come in and see you. They don't actually need to even go to orthopedics because all these will heal. If you splint 24/7 for 6 weeks, they will all heal. I'm sure someone in this audience has had a mallet finger themselves. So full-time splinting of DIP and extension. So just to review, I'll use the mouse, but just to review the anatomy here, because this is super important. So on the extensor side of the finger, you have your lateral band and your central band. Here is the lateral band touching the distal phalanx, attaching at the distal phalanx. The central band attaches at the proximal middle phalanx. And you can see here this white hood. It's called the extensor hood, or another term is central slip, okay? This anatomy we all learned at some point, but I think we all forgot, and it's super important for all finger pathology. Now on the flexor side, you have the flexor digitorum profundus and superficialis, FDP and FDS. FDP opposes the lateral bands at the distal phalanx right here, and FDS opposes the central band at the proximal middle phalanx. Does everyone see that? And don't forget this. This is like the most important anatomy you can know about your finger, about anyone's finger. And if you don't know this anatomy, you will definitely miss pathology. Unfortunately, today we can't cover every single abnormality on a finger. But if you miss a mallet finger, the problem with those is their finger ends up like this. You don't want to miss a mallet finger because it's perfectly treatable. If you don't treat it properly from day one, the surgery is very hard because that tendon retracts. And so it's almost impossible to do the surgery after. So you really got to treat it from day one in the proper way. So make sure that their DIP can extend. And this is the splint. These are the two options. I don't know if wherever you guys are, you have something called a stack splint, but that's what you have like in our orthopedic office. We give them these stack splints that it helps because they're plastic so you can wash them, take them off for a second if they get gross after 6 weeks. But this finger splint is what you typically have, the aluminum one. What I want you to notice about this finger splint, something really important, is that it's only covering the DIP. Do you see here the PIP is totally exposed? You want them to be able to flex their PIP. Why is that? Why do you want them to be able to flex their PIP? What's the downside of splinting the PIP and the DIP? Yeah, that joint gets extremely stiff. The older the patient, the stiffer it gets. But either way, if you splint a joint that doesn't need to be splinted, it gets so stiff, and the PIP gets way stiffer than the DIP. So oftentimes I'll have even colleagues like in the ER will come up to me and be like, I hurt my PIP joint like so long ago and it's not better. That takes months of occupational therapy or hand therapy to get that range of motion back. And the other thing I want to point out to you about this splint here, the aluminum splint that you could do better than in this picture, but I couldn't find one, is to cut out the foam. Do you see this white foam? It's very thick. If you can cut out the foam with your shears and just have the aluminum piece on the top of the finger, that's even better because they can probably flex a little bit against this foam because it's flexible. Does that make sense? So the firmer it is, the better, and you want to hyperextend. So try and curve that up a little bit.